Hello, let's learn about how to interpret microbiology report. Let us start with the appearance of the samples. Sample may be purulent, blood-stained, turbid, or clear. Is there any evidence of inflammation or disease? Then we see purulent appearance of sample, or pussy, or liquid stool. Is, is there any evidence of contact with the non-sterile site or absence of disease? Then we have cellular sputum, epithelial cells in urine, and formed stools. The list of different appearances of microorganisms are present on microscopy. The report, for example, the report shows a gram-positive cocci in change. Then we have to see whether it is consistent with the diagnosis. The patient has signs and symptoms of a respiratory infection such as cough, fever, breathlessness. If a possible diagnosis of pneumonia is made, then the microscopy report of gram-positive cocci in change is significant. How to interpret microscopy? If no pulses are seen in a gram chain, then it rules out the diagnosis of pneumonia. There is no need to culture specimen. Avoid unnecessary sputum cultures. If the gram chain is of high quality, wherein there is less than 10 epithelial cells per field or more than 25 neutrophils per field, and it shows a signal dominant bacterial morphology, it is suggestive of infection, and then it can be used to adjust the antibiotic selection. If the gram chain shows multiple organisms, then it is non-specific and can't be relied upon to modify therapy. If more than 10 epithelial cells and less than 25 pus cells, then it suggests a contamination with the oral microflora. That was about a barless grading system for analyzing whether sputum is significant for either infection, contamination, or colonization. Let us see about urine. How to interpret a microscope in urine. Absence of pyruria largely exclude urinary tract infections. This is a good tool to reduce unnecessary cultures and antibiotics. Presence of pus cells that is more than 10 WBCs per microliter is suggestive of bacteriuria and warrant antibiotic administration, but only in symptomatic patients. As pyruria can occur in the absence of apparent bacterial infections, like antimicrobials, or where there is contamination from vaginal secretions or colonization or catheterization or asymptomatic bacteriuria. It can also be seen in atypical organisms such as chlamydia, uroplasma, and tuberculosis. Now, how to interpret the key phrases in microscopy results? For example, there is a gram-positive cocci in clusters, it suggests staphylococcus. If there is gram-positive in chains, it suggests staphylococcus. Gram-negative coccobacilli suggests hemophilus. Lactose-positive gram-negative rods, it suggests E. coli Klebsiella. Lactose-negative gram-negative rods suggests Pseudomonas. If it is a branching fungal elements, it is a filamentous fungi like Aspergillus zygomycetes. If it is a round yeast, it suggests Cryptococcus. If it is budding cells, it is Candida. So the key phrases in the microscopy can help us to identify or provisionally know and suspect the probability. If the culture and sensitivity are available, and we have to see whether it is consistent with our clinical diagnosis. For example, Streptococcus pneumoniae is cultured from a patient with pneumonia. A list of antibiotics are used to treat the bacteria that is cultured. It is not usually necessary to give every sensitive antibiotic that is listed. So some of the antibiotics can be reported, which can be extrapolated to other antibiotics. How to differentiate infection, contamination, and colonization? For example, let us see. It is necessary to understand the habitat. Let us see the isolation of Enterococcus faecalis from urine. Now, it is imperative to understand that Enterococcus faecalis from urine is important from symptomatic patient, but is of no relevance if isolated from sputum. Then, Candida species are really pathogenic in urine or respiratory cultures. Group B beta hemolytic streptococci does not cause UTI. So, it is necessary to understand the habitat of the organism. Then it's necessary to understand the quantitative values of the bacterial or fungal colonies. Rare, few, moderate, are reported in some cultures. So it is necessary to understand, to quantify and understand the significance of the colonies. It all depends upon the source of the culture, the gram stains, the organism, the contamination, the number of organisms that grow, the patient gender. When a report says rare gram-negative rod, it does not mean that it is an unusual bacterium, but it means that it is present in low numbers. Then we have sterile versus, we also refer to sterile, non-sterile phrases in microbiology. The sterile means the sites normally do not have any bacteria, but non-sterile means they are open to the external environment. For non-sterile samples include throat swabs, skin swabs, wound swabs, and others. While sterile samples include urine, blood, CSF, bile, and others. So it is necessary to understand from the various clinical samples and which are the contaminations in samples and which are the pathogenic in samples. For example, for urine, the pathogens will be Enterobacteriaceae, Pseudomonas, Staph aureus, Staphylococcus, while the contamination will be Coccus nigra, Staphylococci, Corynebacterium, and others. Similarly, in blood, any organism isolated will be pathogens, but the contamination will be Coccus nigra, Staphylococci, alpha hemolytic Streptococci, Bacillus species. So hence, to repeat again, understand the habitat of the organism by interpreting microbes. Then interpreting the blood cultures, it is necessary to collect paired blood cultures from symptomatic patients. That the paired blood cultures consider at least one aerobic and one anaerobic bottle, and from both the hands. It increases the yield of the organism from this patient suspected of infections. How to interpret blood cultures from central lines? Central line cultures turn positive more than 2 hours earlier than the peripheral cultures. Then there is central line blood associated infection. If the central line and peripheral line cultures turn positive within 2 hours, then it may be bacterium from another source or a cell line infection. Central line culture turns positive, but the peripheral cultures are negative, then it is a colonization. Then line removal is. So let us understand interpretation of urine culture. One bacterial species with a colony count of 10 raised to 5 is significant in symptomatic patient. Two type of organisms with one colony count of more than 10 raised to 5 and another less than 10 raised to 5, it is significant. More than two species of microorganisms is always a contamination. Do not treat asymptomatic bacteria except in case of pregnancy or urological procedures. Don't treat contaminants. Counts less than 10 raised to 5 is considered significant in catheterized specimens, acute urological syndrome, patient on antibiotics, urinary tract obstruction, pyelonephritis, and specimen created by suprapubic acid. Similarly, we have interpretation based on colony count in respiratory samples, like in endotracheal samples and bowel samples. No growth of pathogens rules of pneumonia, but a positive cultures from a tracheal aspirate alone don't prove the presence of pneumonia. They may result from colonization rather than infection. Certain species are more likely to represent colonization, for example, Proteus, Cytobacter, and others. So that is about the microscopy and about colonization and infection. Let us sensitive testing. Let us see why sensitive testing is necessary. It is necessary for the selection of a right antibiotic, to monitor the development of resistance, detect new resistance mechanisms, compare the resistance mechanisms among different geographical areas and healthcare settings, and develop and evaluate the interventions and preventive strategies against antimicrobial resistance. To repeat again, collection, storage, and transport is very important, imperative to understand for the correct procedures. For example, blood should not be refrigerated; it should be kept at room temperature and should reach the lab within 2 hours of collection. Similarly, for CSF, it should be processed within 1 hour of collection in the microbiology laboratory. It should also be not be refrigerated; it should be kept at room temperature. If structured organisms like Streptococcus, Haemophilus, or Neisseria meningitis is suspected, then it should be incubated into a 5% carbon dioxide atmosphere or 5% carbon dioxide incubator. Or this, if it is not available, or in better, the CSF sample should be inoculated into a fluid bottle enriched media such as chocolate agar or a food culture automated food culture bottle to increase the yield of the pathogens, especially for pathogen organisms like Streptococcus or Haemophilus. Then we have phenotypic and genotypic methods of the sensory testings. Phenotypic methods are mostly practiced in most of the healthcare settings because it is universally applicable. It is cost effective. It is mechanism independent. It gives a phenotypic categorization. It has a therapeutic relevance too. However, the issue with phenotypic is that it requires time for its growth. It is expression dependent. Genotypic methods are very rapid. Within an hour, they confirm the resistance mechanism. However, if they limited to only few antibiotics, negative does not mean susceptibility, or positive does not necessarily confirm resistance. So that's the issue with the genotypic methods. The phenotypic methods only in this session. The genotypic methods are different based on their method or methodology. There can be disk diffusion or broad dilution and the yield test. It all depends upon the ease of performance, flexibility, reproducibility, reliability, accuracy, preference, and cost that the phenotypic methodology is selected. What does this sensitive testing provide us? It provides qualitative results in terms of sensitive intermediate resistance. Resistance means the treatment failure is expected. Sensitive means the successful treatment is possible. Intermediate means the susceptibility is possible but only at higher doses. Then we have quantitative results in terms of MIC, that is minimum inhibitor concentration. Minimum inhibitor concentration is the concentration of the antibiotic, the minimum concentration of an antibiotic that will inhibit the growth of the bacteria. So how do we do the sensitive testing? If you see the disk diffusion method, here the sample is inoculated into the culture plate, and after an overnight incubation, when we get colonies from the culture plate, that colonies are subcultured into a sensitivity culture plate. And after an overnight incubation, when we get a uniform growth of bacterial colonies on the sensitivity plate, therein we inoculate antibiotic discs, which are paper discs impregnated with antibiotics. They are further incubated for about 18 to 24 hours incubation. After those incubation period, the clear zone is measured with a scale. Based on the diameter of the clear zone, it is interpreted as sensitive, intermediate, or resistant. Let us about this diffusion method. In broad dilution, we have many wells, and each of the wells there is an increasing concentration of the antibiotics that are impregnated. So in this wells which is the antibiotic impregnated, the bacterial solutions, the uniform concentration of the bacterial solution are added, and it is incubated for 80 to. And the next day after the incubation period, the clear zone is interpreted as minimum inhibitor concentration, while the turbid is taken as a resistant. So here from the slide, this the MIC of one is taken as sensitive, while the others are resistant. So important determinant of this pharmacodynamics and pharmacokinetics is in the MIC. MIC is the lowest concentration of antibiotic. Minimum, there is also called as minimum bacterial concentration to minimum inhibitor concentration. When this ratio is less than 4 or equal to 4, it is bacteriostatic. When this ratio is more than 4, it is bacteriostatic. So the majority of the trials have found no difference in the efficacy between bacteriostatic versus bacteriostatic agents. Setting the MIC's breakpoints is multifactorial. It depends upon the clinical data, MIC points, in vitro activity, and in many clinical correlations. That's the pharmacodynamics. Then we have that was about broad dilation. We have E-test method, which is a combination of disc diffusion and a broad strips impregnated with antibiotics in increasing concentration, which is overnight incubated, and after the overnight incubation of the culture plate, this clear zone is measured, and the point where the clear zone is interpreted, it is taken as the MIC. Then we have automated machines like Phoenix and White broad MICs. Out of all the methods, MIC is a broad dilution is the gold standard for sensitivity testing. So that was about the different methods of sensitive testing. Now there are dilemmas. Will the physician understand the test result? How will he act on the test? And he needs to consult with the microbiologist. There needs to be a very strong rapport between the microbiologist and the clinician. While diagnostic stewardship is rationalization of the testings, and the stewardship is rationalization of the antibiotics. So whether the MIC is sensitive or resistant, it all depends on the breakpoints of the MIC, either as susceptible, intermediate, or resistant. So breakpoints is the discriminant concentration which helps in breaking the MICs into either as interpreting the MICs as sensitive, intermediate, resistant based on CLSI, UCAS, or FDA guidelines. It is obtained from the serum levels of the antibiotics, particular resistance mechanisms, and successful therapeutic outcomes. They are obtained from CLSI guidelines and UCAS guidelines. CLSI also has many reference materials, supplementary materials for sensory testings. Also, UCAS has the same reference materials, similar reference materials for sensory testings and interpretation. So understanding breakpoints is very important. For the first, how breakpoints are obtained, they are obtained in 3 steps. One is ECOF values are first determined, then pharmacokinetics and pharmacodynamics indices are applied to the ECOF values, and based on clinical correlations, then we have terms like susceptible, dose dependent. It is similar to intermediate categories, but here in the susceptible, dose dependent, or susceptible increase of exposure means they are proved by strong experimental studies that higher doses will antibiotic efficacy. So this is how the CSI guidelines look like. If they, based on the MICs and the breakpoints, it is interpreted as sensitive, intermediate, or resistant. For example, for cefazolin MIC against E. coli is 1, and if the breakpoint is 2, it is interpreted as sensitive. If the MIC would have been 16, it would have been interpreted as resistant because the resistant breakpoint is 8. So based on the breakpoints, the MICs is interpreted as sensitive, intermediate, resistant. So in the microbiology reports, we find MICs, but it's not on based on MIC. It is based on breakpoints that the MICs are. Also, these breakpoints are different for the same antibiotics for different samples. Also, it differs from sample to samples too. For example, penicillin breakpoints is different from a meningitis sample and different from non. So it's the ratio of the susceptible breakpoint to MIC that is important, and this ratio of more than 2 is taken as significant. That's all. Thank you. We'll see in details about sensory testing interpretation in my next session. Thank you.